In this video, we will be covering mitral regurgitation or mitral insufficiency or mitral incompetence. Mitral regurgitation is a form of valvular heart disease in which the mitral valve is insufficient and does not close properly when the heart pumps out blood. Mitral regurgitation involves blood flowing back from the left ventricle into the left atrium during systole. Often, the margins of the mitral valve cannot close during systole. If the leakage is severe, not enough blood moves through the heart or to the rest of the body. Mitral valve regurgitation can make patients feel very tired or short of breath. What are the causes of mitral regurgitation? The possible causes are mitral valve prolapse. In this condition, the mitral valve's flaps bulge back into the left upper heart chamber when the heart squeezes. This common heart problem can prevent the mitral valve from closing tightly and cause blood to flow backward. Rheumatic fever is a complication of untreated streptococcus infection. Rheumatic fever can damage the mitral valve, leading to mitral valve regurgitation early or later in life. If rheumatic fever causes mitral valve disease, the condition is called rheumatic mitral valve disease. A heart attack can damage the area of heart muscle that supports the mitral valve. If heart attack damage is more sudden, severe, mitral valve regurgitation can occur. A leaky mitral valve caused by heart attack is called ischemic mitral regurgitation. Some people are born with heart structure problem, including damaged heart valves called congenital heart defects. Next cause is thickening of the heart muscle called cardiomyopathy. Cardiomyopathy makes it harder for the heart to pump blood to the rest of the body. The condition can affect how the mitral valve works, causing regurgitation. Next cause is damaged tissue cords. Over time, the pieces of tissue that holds the flaps of the mitral valve to the heart wall may stretch or tear. This is especially likely in people with mitral valve prolapse. A tear can cause blood to suddenly leak through the mitral valve. It may require mitral valve repair surgery. A chest injury also can cause a rupture of the cords. Next cause is inflammation of the inner lining of the heart chambers and valves called endocarditis. This condition is usually caused by an infection. Germs get into the bloodstream and attach to the damaged areas in the heart. Next cause is radiation therapy. Rarely, radiation therapy for cancer that is focused on the chest area can lead to mitral valve regurgitation. Mitral valve regurgitation may be due to myxomatous or connective tissue degeneration, which causes stretching of leaflets and chordae tendineae. Mitral valve regurgitation may be due to a chronic rheumatic heart disease, ischemic heart disease. It can be because of a coronary artery disease, and infective endocarditis may also result due to medications and penetrating and non-penetrating trauma. Now we will see the pathophysiology of mitral regurgitation. The definition of mitral regurgitation is a retrograde flow of blood from the left ventricle into the left atrium through the mitral valve, causing a systolic murmur heard best at the apex of the heart with the sound radiating to the left axilla. Mitral regurgitation may be caused by problems with one or more of the leaflets, the chordae tendineae, the annulus, or the papillary muscles. The mitral valve leaflets may shorten or tear. The chordae tendineae may elongate, shorten, or tear. The annulus may be stretched by heart enlargement or deformed by calcification. The papillary muscle may rupture, stretch, or be pulled out of position by changes in the ventricular wall. The papillary muscle may be unable to contract because of ischemia. Regardless of the cause, blood regurgitates back into the atrium during systole. With each beat of the left ventricle, some of the blood is forced back into the left atrium. Because this blood is added, the left atrium must stretch. It eventually hypertrophies and dilates. Mitral valve regurgitation eventually leads to left ventricular volume overload due to increased stroke volume, caused by increased blood volume within the left atrium and an increased preload delivered to the left ventricle during diastole. The left ventricle volume overload is because with every contraction it now has to pump out not only the volume of blood that goes into the aorta, that is the forward cardiac output or forward stroke volume, but also the blood that regurgitates into the left atrium, that is the regurgitant volume. The combination of the forward stroke volume and the regurgitant volume is known as the total stroke volume of the left ventricle. So, the regurgitant volume causes a volume overload and a pressure overload of the left atrium and the left ventricle. The increased pressure in the left side of the heart may inhibit drainage of blood from the lungs via the pulmonary veins and lead to pulmonary congestion. The backward flow of blood from the ventricle diminishes the volume of blood flowing into the atrium from the lungs. As a result, the lungs become congested, eventually adding extra strain on the right ventricle. Mitral regurgitation ultimately involves the lungs and the right ventricle. The pathophysiology of mitral regurgitation can be broken into three phases of the disease process. They are the acute phase, the chronic compensated phase, and the chronic decompensated phase. Acute mitral regurgitation may occur due to the sudden rupture of the chordae tendineae or papillary muscle. It causes a sudden volume overload of both the left atrium and the left ventricle. The left ventricle develops volume overload because with every contraction it now has to pump out not only the volume of blood that goes into the aorta but also the blood that regurgitates into the left atrium. In the acute setting, the stroke volume of the left ventricle is increased. This happens because of a more complete emptying of the heart. However, as it progresses, the left ventricle volume increases and the contractile function deteriorates, thus leading to dysfunctional left ventricle and a decrease in ejection fraction. The regurgitant volume causes a volume overload and a pressure overload of the left atrium and the left ventricle. The increased pressures in the left side of the heart may inhibit drainage of blood from the lungs via the pulmonary veins and lead to pulmonary congestion. If the mitral regurgitation develops slowly over months to years, or if the acute phase cannot be managed with medical therapy, the individual will enter the chronic compensated phase of the disease. In this phase, the left ventricle develops eccentric hypertrophy in order to better manage the larger than normal stroke volume. The eccentric hypertrophy and an increased diastolic volume combine to increase the stroke volume so that the forward stroke volume approaches the normal levels. In the left atrium, the volume overload causes enlargement of the left atrium, allowing the filling pressure in the left atrium to decrease. This improves the drainage from the pulmonary veins, and the signs and symptoms of pulmonary congestion will decrease. These changes in the left ventricle and the left atrium improves the low forward cardiac output state and the pulmonary congestion that occur in the acute phase of the disease. Individuals in the chronic compensated phase may be asymptomatic and have a normal exercise tolerance. An individual may be in the compensated phase of mitral regurgitation for years, but will eventually develop left ventricular dysfunction. That is a hallmark for the chronic decompensated phase of mitral regurgitation. It is currently unclear what causes an individual to enter the decompensated phase of this disease. However, the decompensated phase is characterized by calcium overload within the cardiac myocytes. In this phase, the ventricular myocardium is no longer able to contract adequately to compensate for the volume overload of mitral regurgitation, and the stroke volume of the left ventricle will decrease. The decreased stroke volume causes a decreased forward cardiac output and an increase in the end systolic volume. The increase in systolic volume translates to increased filling pressures of the left ventricle and increased pulmonary venous congestion. The individual may again have symptoms of congestive heart failure. The left ventricle begins to dilate during this phase. This causes a dilation of the mitral valve annulus, which may worsen the degree of mitral regurgitation. The dilated left ventricle causes an increase in the wall stress of the cardiac chamber as well. While the ejection fraction is less in the chronic decompensated phase than in the acute phase or the chronic compensated phase, it may still be in the normal range and may not decrease until late in the disease course. So, a decreased ejection fraction in an individual with mitral regurgitation and no other cardiac abnormality should alert the physician that the disease may be in its decompensated phase. What are the clinical manifestations of mitral valve regurgitation? Mitral valve regurgitation is often mild and develops slowly. Some people do not have symptoms for many years, but sometimes mitral valve regurgitation develops quickly. When this happens, it is called acute mitral valve regurgitation. Chronic mitral regurgitation is often asymptomatic, but acute mitral regurgitation usually manifests as severe congestive heart failure. Mild mitral regurgitation may not cause any symptoms, but as the leaky valve gets worse and affects the heart function, a common symptom is shortness of breath, that is dyspnea. Patient may feel like can't get enough air into the lungs or have to work harder to breathe when they are resting, lying down, trying to sleep, or are physically active. Other symptoms are irregular heartbeat called an arrhythmia, feelings of a rapid pounding or fluttering heartbeat called palpitations, swollen feet or ankles. Patient may have cough from pulmonary congestion, having atypical chest pain, feeling extremely overtired, that is called fatigue, feeling like patient may faint without actually fainting, that is called pre-syncope. Symptoms of mitral valve regurgitation may develop gradually or suddenly. Assessment and diagnostic findings. A systolic murmur is heard as a high-pitched blowing sound at the apex. The pulse may be regular and of good volume, or it may be irregular as a result of extrasystolic beats or atrial fibrillation. Common tests to diagnose mitral valve regurgitations are echocardiogram. An echocardiogram shows the structure of the mitral valve and blood flow in the heart. A standard echocardiogram is called a transthoracic echocardiogram. It can confirm a diagnosis of mitral valve regurgitation. The test also can tell how severe the condition is. Echocardiography also can help diagnose congenital mitral valve disease, rheumatic mitral valve disease, and other heart valve conditions. Sometimes a more detailed echocardiogram is needed to better see the mitral valve. This test is called a transesophageal echocardiogram. This test creates pictures of the heart from inside the body. Next test is electrocardiogram. This test shows how the heart is beating. An ECG can show irregular heart rhythms related to mitral valve disease. A chest X-ray shows the condition of the heart and lungs. This quick test can help diagnose an enlarged heart or fluid in the lungs. Cardiac MRI uses magnetic fields and radio waves to create detailed picture of the heart. Cardiac MRI may help show the severity of mitral valve regurgitation. Exercise test or stress test. Exercise tests show how the heart reacts to physical activity. The test can show whether the mitral valve regurgitation symptoms occur during exercise. If patient can't exercise, patient might be given medicine that makes the heart work like exercise does. Next test is cardiac catheterization. This test isn't often used to diagnose mitral valve disease, but it can be helpful if other tests have been diagnosed the condition. A doctor guides a thin, flexible tube called a catheter through the blood vessel in the arm or groin. It is moved to an artery in the heart. Dye flows through the tube. This makes the arteries in the heart chambers show up more clearly on X-rays taken during the test. Now we will see the treatment of mitral regurgitation. The goals of mitral valve regurgitation treatment are to help the heart work better, reduce symptoms, to prevent complications. Some people, especially those with mild regurgitation, might not need treatment. The healthcare team considers the symptoms and the stages of regurgitation, among other things, when planning treatment. Treatment of mitral valve regurgitation may include healthy lifestyle changes, regular health checkups, medicine to treat symptoms and to prevent complications such as blood clots, surgery to repair or replace the mitral valve. The treatment of mitral valve depends on the acuteness of the disease and whether there are associated signs of hemodynamic compromise. In general, medical therapy is non-curative and is used for mild to moderate regurgitation or in patients unable to tolerate surgery. In acute mitral regurgitation secondary to a mechanical defect in the heart, that is because of rupture of a papillary muscle or chordae tendineae, the treatment of choice is mitral valve surgery. If the patient is hypotensive prior to the surgical procedure, an intra-aortic balloon pump may be placed in order to improve perfusion of the organs and to decrease the degree of mitral regurgitation. Medicines may be needed to reduce mitral valve regurgitation symptoms and to prevent complications of heart valve disease. If the individual with acute mitral regurgitation is normotensive, vasodilators may be of use to decrease the afterload seen by the left ventricle and thereby decrease the regurgitant fraction. Nitroprusside is the vasodilator is most commonly used. Individuals with chronic mitral regurgitation can be treated with vasodilators as well to decrease afterload. In the chronic stage, the most commonly used agents are ACE inhibitors and hydralazine. The use of ACE inhibitors and hydralazine can delay surgical treatment of mitral regurgitation. If the patient is having hypertension, it limits the use of vasodilators. However, any hypertension is treated aggressively by diuretics and a low sodium diet. High blood pressure makes mitral valve regurgitation worse. If patient has mitral valve regurgitation and high blood pressure, patient may be given medicines to lower blood pressure. Diuretics also reduce or prevents fluid buildup in the lungs and other parts of the body. Blood thinners, also called anticoagulants, also are given to the patient if the patient is having mitral valve prolapse or atrial fibrillation. If patient has atrial fibrillation due to mitral valve regurgitation, these medicines are given to prevent blood clots. Atrial fibrillation increases the risk of blood clots and stroke. Next treatment is surgery or other procedures. A diseased or damaged mitral valve might eventually need to be repaired or replaced even if patient don't have symptoms. Surgery for mitral valve disease includes mitral valve repair and mitral valve replacement. If patient needs surgery for another heart condition, a surgeon might perform mitral valve repair or replacement at the same time as that other surgery. Mitral valve repair saves the existing valve and may save heart function. Whenever possible, mitral valve repair is recommended before considering valve replacement. People who have mitral valve repair for mitral regurgitation generally have good outcomes. During mitral valve repair surgery, the surgeon might patch holes in heart valve, reconnect the valve flaps, remove excess tissue from the valve so that the flaps can close tightly, repair the structure of the mitral valve by replacing cords that support it, separate valve leaflet that have connected. Mitral valve repair procedures are annuloplasty. A surgeon tightens or reinforces the ring around the valve called the annulus. Annuloplasty may be done with other techniques to repair a heart valve. Next procedure is valvuloplasty. This treatment is used to repair a mitral valve with a narrower opening. It might be done even if patient don't have symptoms. It is done using a thin tube called a catheter with a balloon on the tip. The surgeon inserts the tube into the artery in the arm or groin and guides it to the mitral valve. The balloon is inflated, widening the mitral valve opening. The balloon is then deflated and the catheter and balloon are removed. Next procedure is mitral valve clip. In this treatment, a doctor guides a catheter with a clip on its end to the mitral valve through an artery in the groin. The clip is used to improve the closure of the mitral valve leaflets. It reduces the amount of regurgitation. This procedure is an option for people who have severe mitral valve regurgitation or who aren't good candidates for mitral valve surgery. Next surgical procedure is mitral valve replacement. During mitral valve replacement, the surgeon removes the mitral valve. It is replaced with a mechanical valve or valve made from cow, pig or human heart tissue. A tissue valve also is called a biological tissue valve. If patient had mitral valve replacement with a mechanical valve, patient need to take blood thinners for life to prevent blood clots. Biological tissue valve break down over time and usually need to be replaced.